Hi, good evening, everyone. Okay, do you mind taking out your slides first so that we can chit-chat a little bit?
All right. So I stop sharing, huh?
Stop sharing for a while, yes.
All right.
Okay. Hi, good evening, everyone. So we're very excited because we were off for a month, a good month, which I had a good rest. And we'd like to invite Puan Miniswari. Can you please maybe introduce yourself a bit? Tell us something about you, where you work and what position you hold. How do you actually come to this this corporate level that you are in? Okay.
Okay. Okay. Good evening, Dr. Betty and all. My
Yeah.
name is Muniswari Velaudan. Currently, I'm working in KPJ Sabah Specialist Hospital as a Chief Nursing Officer. Okay, I've been in nursing for 26 years. So I started my career in College of Nursing. I started my basic nursing in Asunta College of Nursing.
Oh, I see.
Then
Very
I did
good.
my midwifery in HKL. I also did my degree in Hertfordshire University.
And this was
My,
your degree was how many years after you practiced as a nurse?
it was about 9 years.
After
My post-basic was even faster, after 2 years. My degree was after 9 years, yes.
And you immediately knew you wanted to do midwifery?
Because the hospital sponsored me was Chinese Maternity Hospital. So
Oh,
they sponsored me for midwifery. So I completed that, working in medical, surgical, labor and delivery. Then when I did my degree, I was promoted as a unit manager in surgical ward. Then I also worked in medical, ICU, and my last career was in KPJ Kajang Specialist Hospital as a unit manager in accident in emergency for 9 years, about 8 years, before I was promoted and transferred to KPJ Sabah as a Chief Nursing Officer.
congratulations. It's quite a path that not many people can achieve, Chief Nursing Officer. But a lot of the nurses out there must realize that nursing is a profession that is actually very in demand. Nursing is a profession that has a lot of options for the nurses out there, not just clinical work, but also hospital admin and also corporate level. Yeah. So without further ado, we go into your slides and your talk on CTG. I myself have never done obstetric before because I really do not like obstetric. And to all the nurses out there, can you tell your friends that our Zoom is already full? So for all those who want to watch this, to go into Facebook Live. Okay, let's share your slide.
Okay. Can you see Dr. Betty?
Yeah, give it a minute. There. Okay, now you press slideshow. You see the slideshow, the orange one? The orange at the top there next to animation. Okay, on the top menu, go straight and you'll see slideshow. Can you see it? Okay, where's your cursor now?
New share, not new share.
No, not new share. Where's new share? Okay, on just right on top, just at where your KPJ Sabah, to the right a bit, and on top there you see slideshow.
Okay, stop share.
Stop share.
Okay.
Share screen.
Oh, okay, you got it.
All right.
Now, this is a very, very important topic for a lot of nurses out there, yeah, because we are responsible for 2 lives here, and one is inside the mom. Come, go on.
Okay. Okay, first of all, thank you so much to all for taking your time and attending the webinar tonight. I'm really pleased to share knowledge on nurses' role and responsibilities on CTG. And I also would like to tell why I choose to share this topic is because the primary purpose of CTG is to detect early signs of intrapartum hypoxia and improve fetal outcomes by expedite the delivery. Besides that, CTG also provides a continuous indication of fetal responses to uterine contraction and intervention. Okay. The slides are not moving. So that's the topic for tonight, nurses' role and responsibilities. All right, read. Before that? Okay, before that, I would like to show my beautiful hospital where I work, CTG Sabah Specialist Hospital. Okay. Okay. At the end of this topic, so nurses should be able to know what is CTG and its components, to describe the purpose of CTG, and also to describe nurses' role and responsibilities in CTG monitoring. So what is CTG actually is cardiotocography. Cardio means stands for the fetal heart rate, and toco is a uterine contraction, and graph is the recording which generate on the tracing. So recording the fetal heartbeat and the uterine contraction during the pregnancy and labor. Okay, that's basically what is CTG stands for. Okay, now let's see the components of the CTG machine. There is a two transducer, if you see, there's a toco probe and cardio probe. Both these probes are attached to the abdomen of the mother. So the toco probe is placed at the fundus of the uterus. This is to monitor the uterine contraction. And the cardiac probe is placed at the fetal back of the fetal back to monitor the fetal heart rate. So these two probes are very important. So before you apply, you have to do an abdominal palpation to locate where is the fundus and also the fetal back.
Sorry, can I ask you, does it matter what position the baby may be in?
Okay, if the baby is vertex, which means the presentation of the head is down, it's more easier to locate. If the baby is bridge, and it will be slightly different location. So you really need to palpate and get the fetal back for you to put on the cardio probe.
Okay.
Yeah, you need to have that abdominal palpation knowledge. Okay, I will just talk about a little bit of the probes, how they actually detect. Actually, the toco contains a flexible disc that respond to the pressure. So when the uterus contract, the fundus tightens and the change in the pressure against the toco is amplified and conveyed to the electronic fetal monitor. So the monitor display the uterine contraction as a pattern, and at the graph paper, that's where you see the contractions like mountains on the graph. And the same with the cardio probe also. That's why it will detect the fetal heart rate. Okay, now we see what is the purpose of CTG. So used to monitor fetal heart rate as well as the contraction of the uterus, to monitor fetal well-being and allow early detection of the fetal distress. So usually what we will tell the mother is, we want to know whether your baby is happy inside the uterus, getting enough oxygen, or the baby is distressed, insufficient of oxygen. It can be detected by the CTG tracing. Okay, this is the most important roles, nurses' roles and responsibilities. It divided into three: before, during, and after. So usually what you should do before, get informed consent from the mother and explain regarding the procedure to her, especially how long the duration, the procedure takes, and what is expected from the mother. First of all, we should ensure her comfort, which means offer her to go to the toilet, to empty her bladder, her bowels, because if bladder and bowels are full, she's going to be very uncomfortable lying down there with the abdomen tied up with the belts. So we ensure she empty her bladder and bowels. Okay, and then during the procedure, provide proper position. Usually we will position the mother supine position and provide privacy, especially when the abdomen is uncovered. Usually this procedure required to expose the entire abdomen. So we need to cover the abdomen to provide privacy to the mother. After the procedure, very important, a proper documentation is done timely. Okay, another one important thing is setting the CTG machine. Actually, this is how you set the CTG machine paper. It's either 1 cm per minute or 3 cm per minute, because you need to know which setting you did. Because if you do it 3 cm per minute, it's going to show the reading a bit longer and wider. So you have to ensure that which setting you do it to the paper. The ideal setting is 1 cm per minute or 3 cm per minute. Okay, the next is fill in the mother's details. Of course, before you fill in, you have to check for the date and the time is accurate. And then fill in the mother's detail correctly with full name, identification, and medical registration number of the mother. Okay, after you put up the details on the paper, then preparation of the mother. Explain to the mother the purpose. It's actually baseline reading for every woman who goes into labor, and it's going to be continuous. Of course, you have to explain to her, is it going to be continuous monitoring or intermittent monitoring? Yes, if she is in active labor, high risk, or she's on Pitocin drip or epidural, is going to be a continuous CTG monitoring. If the mother is early labor, CTG monitoring will be done intermittently, which means duration of 20 to 30 minutes every 1 or 2 hours. That also depends on the CTG tracing, whether it's reassuring or non-reassuring. Okay, the next is provide comfort to the mother. Cover the patient, do not expose her abdomen, ensure she's lying comfortably. And then reassurance and emotional support. If the husband is around, allow the husband to accompany the patient to give the extra emotional support to the mother. Record the maternal observation timely and also the proper placement of the props. Because if you don't, like what Dr. Betty asked me just now, right? The placing of the props, if you don't put it properly, the tracing will not be accurate. Of course, the very important thing here is the knowledge of the CTG. The nurse who proceed this procedure, she should have at least a basic CTG interpretation knowledge. Actually, CTG interpretation is a totally a different topic, but I will just briefly explain. You can use this method, Dr. C. Brevodo. Okay. Doctor stands for defined risk. This can be both for maternal and also for fetal risk. And C stands for contraction. So the nurse should know what is the normal contraction. In 10 minutes, it's okay to have 5 contractions. If the mother is on Pitocin and she's having more than 5 contractions, which means it's hyperstimulation. So intervention have to be taken. And the B stands for baseline rate. The nurse need to know what is the normal fetal heart rate, which is 110 to 160 beat per minute. So when it's more than that, it's tachycardia, and if it's less than that, the baby is going into bradycardia. And the next one is VA, is variability. It's also very important, is the beat to beat variability. The normal one is 5 to 25 beats per minute. The last one, O stands for overall impression of the CTG interpretation. If there is 2 or more features non-reassuring, you need to report to the consultant immediately. Example, reduced variability. The CTG shows prolonged brady, or also presence of late deceleration in the CTGs. You have to inform the consultants immediately, which shows the sign the baby is distressed and the delivery need to be expedited. Okay, the next is monitor CTG closely. We're able to detect the changes. If there's any CTG interpretation shows non-reassuring, you need to notify immediately for intervention to be done. Of course, you have to do the documentation. And also, we have to work as a team to go on everything smoothly.
When you put the patient on CTG, right?
Yeah.
How often do you check on this CTG as a nurse? You can't be watching it all the time, right?
If a high risk patient,
You have to watch it all the time.
yes, if you already found one late decel or the baby is going on bready,
Hmm.
you try to reposition the mother. You put the mother left lateral position for better blood flow.
Mhm.
If still is go on bready, you have to immediately inform
So
the
you
consultant.
really have to keep your eye completely
Yeah.
on this CTG.
Yeah, unless it's early labor, you
Uh-huh.
put the CTG and you monitor for 10 minutes, looks very reassuring. Everything is normal parameters. You can monitor for 30 minutes and then again you repeat after 1 hour. You don't have to sit there and monitor continuously.
I see. So it is very, very important. This
Yes.
is a very, very important topic. And this is a topic where there are more and more legal implications for doctors especially, and eventually for nurses too.
Yes.
And parents will sue, okay, medical team. So when you work as a team, you may get sued as a team also. Okay, we go on first.
So again, keep the mother update regarding the baby's condition, because once the CTG is not reassuring, you will inform the consultant immediately. So of course, the consultant will give you some orders. If it's after office hours, they are away. So you'll be doing some procedures. You have to explain. Maybe you're preparing her for a C-section. Explain the procedure that will be carried out, which will help the mother to relieve her anxiety. And of course, you have to continuous giving her the emotional support. Okay, this is some of the scenarios. I want to get rid of this. I can't. Okay. Okay, this is a 31 years old mother, Gravida 2. When the midwife was beside me, I feel relief. I really needed that have consistently supported during labor and delivery. This is what I mean,
Yes.
verbalized by a mother,
Hmm.
how the emotional support was given. And the second scenario was a 42 years old Gravida 3. She verbalized, when the midwife encouraged me during labor, I felt that I could handle more my pain. And the third scenario was a Gravida 1, 28 years old young mother. The empathy and kindness of midwife really relaxed me when she was good-tempered with me. I felt that I was in control. Emotional support. And also very important for all the legal cases, ensure completeness of documentation. Accurate and complete documentation. Ensure the CTG is kept in the mother's case note and the right mother's case note by doing the proper identification. And for high-risk cases, it's advisable to keep a CTG copy for further reference. Okay. Make the mother comfortable after the procedure. Clean the mother, because the transducer or the probe that we use, there's a gel. So you have to clean, wipe the gel to make the mother more comfortable, and also inform the CTG findings to the mother. Whether the baby is good, happy, enough of oxygen, the CTG shows reassuring, or any intervention to be taken that we already informed the doctor, everything, we must keep informing the mother. Okay, this is summary nurses' roles and responsibilities. So before, prepare the CTG machine, including the putting in the setting of the CTG paper, fill in mother's details accurately, preparation of the mother, knowledge about the CTG, and during, monitor the CTG closely, maintain communication with the mother to make the mother comfortable. And after the procedure, ensure completeness of the documentation, make mother comfortable, and lastly, clean the CTG machine. In conclusion, midwives are givers of laboring women. Therefore, we must have adequate knowledge of CTG, able to document it properly. Nurse must be competent in assessing fetal heart rate patterns and perform independent nursing intervention report to the physician immediately to prevent further harm to the fetus. The emotional, informational, and comfort needs of the woman and a bird accompany must be addressed to the mother and the fetus are being monitored. Okay, I'm almost finishing my presentation, and this is the take-home message. The greatest privilege of a human life is to become a midwife to the awakening of the soul in another person.
Wow. Do you have any what you call it? Questions for them? You didn't? Okay, don't worry.
Okay.
We
Can
will
I have two features of non-reassuring CTGs?
two features of non-reassuring CTG.
CTG, which is alarming and you need to call the consultant immediately.
Okay, girls, come. Two alarming. Two alarming what again? Two alarming characteristics.
Non-reassuring CTG.
Yeah, non-reassuring.
That means
Means you need to, okay, bradycardia, okay. Anyone else?
Yep.
One of it is bradycardia, correct? Actually, you can name more. Type 1 deep, bradycardia or tachycardia, true.
Early deceleration.
Okay. What else? Anyone else? Come on. Even the contraction also, right?
Yeah, that one when the mother is in pitocin, it can be hyperstimulation, whereby we need to stop.
And variation in the heart
Reduce
rate.
prolonged bradycardia and reduced variability. That are the typical signs showing the baby is hypoxia. The fetus is hypoxia.
Deceleration. Type 2 deceleration. What is type? Okay, there's one person who says type 1 deep, and there's another person in Facebook says type 2 deceleration. Can you just explain to me what these two, what are the differences in these two, type 1 and type 2?
Okay, type 2 is late deceleration, whereby when the mother gets the contraction, the fetal heart drops.
Oh, I see.
Which means the the fetus is compromised.
Okay, type 1?
That is dangerous. Type 1 is during the contraction.
So type 2 is when no contraction, but the fetal heart drop.
No, with the contraction. It drops after the contractions.
After the contraction.
Yes.
So both are very prolonged deceleration of more than 4 minutes. Somebody said, Pramit Gill said that on Facebook. So,
yes.
So obviously
these are all the signs of baby is hypoxia.
Yes. So the girls are actually truly listening in, yeah?
Yeah, they're listening. Actually, when the baby becomes a bit bradycardia, we don't straight away call, we put the baby mother to the left lateral position.
So the left lateral, why left lateral, may I ask? Why not right?
For the better blood flow, where the vena cava gives a better blood flow to the placenta and the baby gets oxygen.
I see. So it's always left lateral.
Yes, it's always left lateral. Yeah, but we don't do it too long. We just try. Put it for a few minutes. Then we see how is the tracing going on. If still it's ready, we will quickly inform the doctor.
Okay. Can I ask why? Okay. How are people more prone to going to do Caesar these days? Are doctors more prone to doing Caesar these days?
Yeah. Okay. Let's say if lady is in labor, active labor, the doctor ruptures the membrane, and then it's going to be a meconium stain liquor. With the meconium stain liquor and the CTG is not good, definitely the mother the patient have to go for cesarean section.
Yes.
For fast delivery and to have a good ABGA score when the baby is out.
Okay, Eng Xuan said type 1 is also known as mirror image. Means
Yeah,
if
mirror image. Yeah.
baby-
During the contraction, which means during the contraction, you have a mountain figure. And the fetal heart also gives you another mountain
Oh,
figure.
I see.
Drop. Yeah, that's what they
Drop.
call as a mirror image.
Oh, very interesting.
Yeah, there's 4 types of deceleration actually.
Oh, there are 4 types of deceleration. And of course, as the first, second, third, and fourth, the worse it gets now.
Yeah, the late deceleration is worse.
Okay. Can you now question number 2?
Question number 2.
Okay. Let me see any questions from the girls or not? Any questions at all? Is there a newer method other than CTG?
There's no newer method, but the CTG machine has improved a lot now. They have cordless.
Okay, but
They have,
basically the graph and the
it's the same. It's
is
the same.
same, right?
Yeah.
It's just that how convenient it makes for
Yeah.
us to work on.
Exactly. If like the mother is still in early labor, with the cordless one, they can still walk, they can sit, they don't have to lie all the time. That is the
Oh, I
changes.
see.
But at the paper and the setting is always the same.
And this CTG must be a very old invention that has really been very useful for us, yeah?
Yeah, very useful.
Very useful. Any question at all? Any questions at all? Okay, I'm going to share, okay, let me see. I will share this. Okay, let me just give me a moment. I will share the CTG e-cert. So let me just explain. It's a very simple thing. Okay. So I will put it in the chat whereby there is an e-cert form which you fill up and then you will submit it and we will send you an e-cert eventually. And we also will do it to the same for people who are watching in Facebook. No questions at all. You understand it so well.
Hopefully everyone understand it well.
Yes. Next time we will do, I think next time I will ask the speaker to give about 4 quizzes. That's what
Okay,
we did, but
quizzes.
yes, just 3-4 questions and then, yes, because your webinar is quite fast, yeah?
Yeah.
Even 20 minutes also quite fast. Okay, so all the nurses, please, can you settle your e-cert soon? Because we can then end the webinar. Okay, I'm going to stop recording.